I'm Saba Masho from Virginia Commonwealth University, and I'm going to be talking about the research. But before I start, I want to say thank you for the people who I have been working with for several years, particularly Rose Singleton, who has been my partner in crime in every work that I do, but also she raised the bar for me in terms of engaging me with the community-based level work that I have been doing. And she's been really the brain, half of my brain, to really intrigue me in thinking a lot of the research projects that we have done in the past. And also I'd like to thank the Institute of Women's Health for having me and being able to work with the Institute for several years. So I just wanted to give the people who needs the acknowledgement. And so in terms of the work that we need to do, let me figure out this thing. Nope. Am I good? That's okay, I can. No, that's not me. Okay. If you don't have it, that's all right. All right, I have my printout. Okay. So I'm going to start with, all right, how do you, as a researcher, I come from a research perspective, so as a researcher working with communities, how do you come up with research projects that addresses the needs of the community? And particularly when it comes to the breastfeeding issue that we are having in our community, one of the biggest challenges was how do we really understand what's going on within our community and be able to help them with the work that they need to be done. So the first thing when the commissioner, when the mayor decided breastfeeding is the priority for our city, our job is as a researcher, what are the primary things that we need to do to assist the community to understand this is really important? Because if you do work without community awareness, then you're going to run into problems, because if community doesn't think this is a problem to them, and if they are happy with the usual care, then you don't have anything to work with. So our job is really to identify what are the problems. So the first thing that we did was to understand or help the communities understand what are the benefits of breastfeeding to the child, to the mom, and also to the society. That's really a major problem. So one of the things that people are interested in is how much money do we save by breastfeeding? So what's the cost to the society? What's the cost to the mother, to the family, as well as to everyone else involved? So overall, nearly 13 billion dollars could be saved by just breastfeeding, and also just from cost related to the mother. And if we take into consideration the issues that are involved or involving children, affecting children, some of the problems like ear infection or respiratory tract infection, those kinds of things, we could be able to save about $18.3 billion. So those are really major savings from our community that we can work with, and we can understand. And clearly knowing those kinds of costs associated with them, and also the health benefits to the mom and to the child, and helping the communities understand in their own words is really a great benefit to our community. And in addition to that, working with our partners, especially with our community partners, the major issue is also understanding where are we going, where are we at. So the where are we at is going to be what are the numbers for my community, and that's going to need a lot of work. Particularly, a lot of the data that you may see is really at a state level, or sometimes if you're lucky you get it at a county level, but you don't know anything what's happening within your neighborhood level. So one of the things that we have done is work with the local community, especially WIC. Some of the data that they gather information about breastfeeding, And that kind of information is helpful to actually conduct some small area data analysis to understand the rates and some of the issues surrounding breastfeeding in those small areas. And then when you take it, we do nice maps, showing each area, each by census tract, if you will, and we show them to those communities and say, hey, this is the way it looks compared to the people who are living, let's say, in our community in the city. If you live in the east side, at the east end, or a little north or south side, it's mostly deprived. But if you live on the west end, it's more of high income or affluent society. So just showing that contrast to the community, that's kind of a wake-up call for people to say, oh, that's, do rich people actually breastfeed? Versus, oh, I thought, the right thing to do is really to feed your child a formula. So those are some of the questions that the community could bring in, and being able to see those numbers and then compare it to what's the goal of, for example, 2020, or what should be the goal for you to achieve the level of rates that for your community. So that's kind of helpful in terms of from university community partnerships to bring in some of the data to bring back to our communities. So my other thing is also, what do we know? One thing that you do not want to do is really replicate. Replication to some extent is good because you need to confirm that it works in your community. However, doing everything that's done before doesn't make sense as much. So the first thing that you may want to, from our perspective, the contributions that we can make in our community is, what does the research say? And what do we know within our research? What's already investigated and what's not known? And that's going to be very important from many perspectives. One is, for research. The other is really guiding community interventions and also framing really a nice theoretical framework to guide your interventions. You want to be effective and also efficient and efficacious in the work that you're doing. And you need to make sure that the money you have is sufficient to do your work. So if it is guided by framework that's already studied or investigated, then it's really to your benefit, and you show the work and the benefit in your community. And most of the time, we do work that we feel good about. And it's, if you don't have the evidence for that work, then really you don't have anything to show for it. Sometimes we feel like, oh, I know it makes a difference, but show me the data, and you don't have it. That's going to be a big problem. So the first thing that we did was really looking what's known and what's not known. And also in terms of monitoring your data and your work, how much of the data do you need, or how much of the data do you need to evaluate or monitor your program? So most of the things that are already known and that we were able to present to our communities when we work with them is really the biggest challenge was perceived insufficient milk. Most women always feel like, and I remember myself too, that you don't have enough milk. The first time I became a mom, I didn't have anyone. I was just by myself, and I just wasn't so sure. And my baby wasn't stopping. She kept crying, and I was just like, I'm not planning to really give her formula, but I didn't know whether it was sufficient or not. So I had the commitment and the determination to do it, and I breastfed both of my kids for a year. But if I was a mother who was, who didn't know, definitely that was really a breaking moment. It was really tough. So that's some of the things that's already known that most moms don't have any understanding, that when you're faced with that situation, how to deal with that kind of problems. Another thing that we know most is technical difficulties with breastfeeding, that research has demonstrated time and again. Some of the technical difficulties that you feel like, okay, I can latch on like in a second, but it doesn't happen. You really have to know the techniques, and you should be educated about those as well. Another bigger challenge is also going back to work, and we all know how challenging that is, leaving a baby who's 100% dependent on you to someone else, and then not being able to feed, and how difficult that is, pumping every 3 hours. I've done it, how difficult that is also. Having a little bit of readiness is always important. and also having a community that understands, so that your workplace has lactation rooms or any type of supportive services that you may have. Your employer is happy that you're breastfeeding, versus like, oh, if you're breastfeeding, maybe you're not doing your work, so those are really some of the challenges that mothers feel. And another thing is fathers' involvement, and we just did a research about fathers' involvement and how that impacts breastfeeding. The more the support there is, the better it is, and particularly the partner support is very, very important, because perception of our body is important, and also the function of our body is also important. So that's another piece of work that's known. In terms of maternal behavior, smoking, for example, is a major challenge. And most mothers, regardless of where they are coming from, they want to be good for their babies, and they want to make sure that they are providing the best milk to their babies. And if I'm a smoker, that's something that they always worry about. If I'm a smoker, maybe I shouldn't be, breastfeeding. How can I get? What's the content of my milk? That's a major concern for most mothers. So they have to be cognizant of that. And from healthcare providers, that's also another thing that a lot of work has been done in terms of communication. Patient-provider communication is a major thing. And earlier this morning we talked about the centering pregnancy, how that or the group pregnancy model, how that's helpful in terms of engaging mothers and also helping providers communicate effectively and repeatedly, just not one time, but repeatedly just discussing that, because decisions don't happen just in one time. This is really a process, and women have to be ready for that. And we know a lot more, and of course some of the demographic factors are already known. However, there are some things that we know not so much. However, the Surgeon General called for action in 2011, as you know, that the lack of knowledge is one of the priority areas that we really need to focus on. Attitude, skills, and self-efficacy is another area that we really need to understand. Confidence and commitment building is also another research area, especially thinking about minorities or communities of disadvantaged communities in terms of building those kinds of confidence within those communities are going to be very, very important. Social and cultural norms are absolutely important areas that we need to focus on. Social support, work environment. Another thing is really the media influences. And a lot has been done, but little has been evaluated. And we don't know much about what's happening in the media world and how women's body are portrayed, and also some of the social media, how things are portrayed. Little has been done, and that is also another area of research that needs to be focused. And recently, thinking about body and body image, we just had with my research assistants, we just published an article on breastfeeding medicine that was highlighted, I think, a couple of weeks. It just got accepted and was highlighted a few weeks ago, maybe a week ago, on the website, was looking at obesity, overweight, and also how that affects breastfeeding. And we know that breastfeeding is helpful to reduce weight or lose some of the weight that we gain during pregnancy. But little is known that women who are obese and overweight actually do not want to breastfeed for many reasons. And image is a very important thing. So when you have body where it is bigger, then it is more difficult for you to even initiate it. So even initiation is really, really difficult. And some of our research is also shown, which we are preparing we just submitted actually, is looking at with obesity and breastfeeding in the role of marital status. So married women actually have much more difficulty in engaging in breastfeeding or also including duration, than non-married women. Married women don't want to breastfeed and don't breastfeed longer. So that also ties into really the idea of the partner and also image, self-image, and how we perceive our body is very, very important, and further research is needed in that area. So moving forward in terms of gaps in breastfeeding research. According to the center, the CDC, in 2013, there are few. Oh, we got it.
Yes. So
okay.
We did have it.
Oh, we did. No, that's okay. That's fine. So we got that. So basically, these are some of the things that that the CDC came up with, is really understanding the barriers among populations with low breastfeeding, and we're going to be talking about those a little later too from Richmond perspective, but particularly among African Americans. If you look at all of the data, and I think somebody else showed it before too, the numbers, the rates are very low, and it seems like different segments of population have different rates. And some are catching up faster and some are slowly catching up. But this is an area that we need to look at, and CDC believes that this is an area that we need to investigate further. Another thing is the economic impact. So we talked about early on, I just told you how much society could save by breastfeeding. And that's known. However, when you're asking a mother, it saves you money, she's gonna think, okay, I save money from formula, but if I'm working, am I really saving, or am I staying at home and have to be breastfeeding? So you really have to weigh, if I go out, I have money, even more money to buy formula. If I stay in, I can breastfeed, but I'm losing some money. So that kind of conversation has to be supported by research, and we need to do more work in that aspect moving forward. And also best practices of management of lactation and lactation support is also lacking in terms of social support. This is an area that's emerging. We don't have a lot of measures that we are able to measure this, but that's also an area that we need to think about. Other important gaps in research are exclusivity. And we know that we have to, we do have the guideline, but exclusive breastfeeding is understudied, and a lot of people don't do that, as we know. But what are the barriers for exclusivity, and how do we implement that, and how do we manage that? And those are really good, important questions that we need to understand from cultural perspective. For example, we did some work that we published with the Hispanic, with the Latina moms. And they do breastfeed. Their rates are good. However, they supplement from day one. And formula feed, they love their babies to be a little chubbier. We love them. Of course, they look beautiful. But at the same time, it's just the overfeeding aspect of it. That's not studied as well. And a lot of the work that we did from focus groups and qualitative studies is really giving us indication. It's more of the, we love this kind of baby. It's not sufficient not to feed your baby enough. Breastfeeding may not be enough for me. That's one thing that we are learning. So, and then the other thing is really breastfeeding policies that we need a lot of work in terms of examining that. So why are these gaps really important in addressing this issue? So the first thing that we talked about was really minority populations, and I'm going to talk more about African American population, mainly because that's where I work. And looking at Richmond City, where we came from, the population, the majority of the population is actually African American, and it's poverty-stricken, and they are aggregated in certain localities. And as a result, you can see some of the rates in this data, which shows that the rates are much lower compared to any other racial or ethnic group, whether it's ever breastfeeding for 6 months or breastfeeding for 12 months, the rates are much lower. And that's why we need to focus on areas that where we could make a difference to raise the bar up a little bit. And you probably know a lot of research with infant mortality. The biggest problem with infant mortality is when you look at racial differences, you will see infant mortality in higher income populations is low, but it is really the low income population or the racial minorities population are the ones who are really carrying that heavy burden. So if we improve that area, our numbers goes up quickly. So that's why we need to focus in areas where we need to have a difference. And then the next area is really thinking about the economic impact. Oops, what did I do? All right. All right. No, I think I went too far. All right, so from the economic impact, it's really essential that it seems to jump for some reason. All right, I'm just gonna stop here and then talk about. All right, okay, that was it, right. So from economic impact, I just mentioned some of the things that from parent, perspective, from insurance perspective, that's an area that's not touched yet in terms of insurance, how much of it is supported. In Virginia, we just got an approval that now lactation consultants could actually bill and they could be paid. And those are really important things because there is no way we can sustain breastfeeding counseling or lactation consulting is going to be sustained. There is no way we can sustain them without having those types of policies in place. And we need to understand the economic impact and the potential for future, in terms of future generation. This is going to take, it took a very long time. If you go to developing nations, that's what they depend. They breastfeed, and that's it. But for us to lose it this much, it took years. To gain it back, it's going to take years. So we need to work harder to get it to that place. So that's going to be very important. From best practice perspective, we need to really learn from the international world. There are a lot of best practices that are already done, and there is a great body of work with the World Health Organizations that we have a lot of work that was done, and also other countries' policies. For example, in Scandinavian countries, they do breastfeed, and culturally it's acceptable. You go to places in a restaurant, women don't feel any badly. They just take out their babies and feed them, and that's norm. And that's acceptable in a developing country. And for example, here at the bottom in Norway, only 1% of infants never receive breastfeeding. How about that? This is Norway, and only 1%. So think of where we are now and where we want to be. And these are communities that have similar cultural environment. Of course, definitely that's predominantly Caucasian society, but still really a good place to be. So it's really important that we learn from other countries, and I see that there are a lot of international perspective here also, but there is so much more to be learned from the society. So WHO, of course, recommends breastfeeding exclusively for 6 months, and however, we don't adhere to that, especially within the United States. And only 18% or nearly 19% exclusively breastfeed, according to the 2011 data. So we do need to have significant research to understand why that's not happening, and we really need to address those issues moving forward. And then, so thinking about moving forward, what are the evidence-based practices? A lot of times we come up with this wonderful idea, but how much of it do we have evidence? And these are some of the evidence-based practices that are already known, seem to work. We have data for, such as maternity care practices. Those are really a lot. We have a lot of data in that area. We do have a lot of information about support in workplace. That's very, very important. I wouldn't have done it if I didn't have support in my workplace. With my first child, I was really supported. I pumped throughout. With my second child, I had at VCU as well when I had my second child, and we do have child care facility within a walking distance. So every 3 hours, I was able to go feed my baby, come back to work, and I was feeling comfortable. So those are really good things for people, especially for women who are in workplace. Peer support. We were talking at lunch about peer support. That's really known, and there is strong evidence that it shows. Some programs are evidence-based, and some programs may not be. Some are really going to that evidence-based status, but there are evidence-based peer support programs that are already known. And educating mothers that seems to work, and we should continue to educate mothers. Definitely, that's the knowledge piece that we need to have. Professional support is key. The lactation consultants, the doulas that we work with, those are really important people who are able to help our people. Media and marketing is also very, very important, that we haven't been doing as much of when it comes to breastfeeding because of the cultural hindrances that we have. We don't do those as much. However, there are areas that we don't have a lot of supported evidence. For example, counter marketing, does that help or doesn't help? We don't know much about that. Professional education is another one. I'm engaged, I'm an educator as well, and I do teach in the medical school, and most of our physicians, we don't teach them how to do this. In our curriculum, we have to work hard to incorporate breastfeeding education as part of. It's really the nurse's job. It's not the physician's job. That should go. That should go away. Although we don't have evidence, we have to really start working to get those evidence so that educators should understand this type of work is important and also incorporated in our curriculums as well. Public acceptance, that's also a lot of work that needs to happen. We don't have research to support it or not support it. That's the perception that we have. A lot of people feel terrible to breastfeed in public, but we don't know what the public thinks. But it goes with education, and we need to do more work in terms of research going further. Hotlines and other forms of information, we don't know much about those as well. We need to investigate further. And the social media, all that information that's out there, we don't know much about it. That needs to be investigated. So in terms of really moving forward and doing research, there are so many areas that we can work on, and we could examine further. For us, we would love to really work more on the cost of breastfeeding aspect of it and exclusivity aspect of it as well, especially among minority population. What are the barriers, what are the problems, and how do we overcome them, and what works better? Because as much as we know the barriers, sometimes we don't focus on the positives. We always focus on the negatives. So what are the good things that communities have, and build from there is also going to be very important. Another area that we don't know much about between directly breastfeeding versus pumped feeding. Does it have, we always talk about that bonding and those kinds of things that has benefits, but we also encourage women to pump, and that's also another question. Because I pump, is it less beneficial to my baby? And we have the evidence for that, and we need more research to really inform our population on that. So some of the challenges that we have in terms of research is really, the best research is when you do randomized clinical trial, right? But it's very hard when you have, you can't deprive people, randomize someone to breastfeed and not to breastfeed. So the ethical aspect of it is really a challenge. So we are ending up with a methodology that's not, high quality, considered high quality. So basically that's a major problem. There are so differing breastfeeding definitions, especially when you think about initiating. So at the hospital, we always encourage women to start breastfeeding, and they latch on that one time, but as soon as they leave home, they stop. But is that still considered as breastfeed or not breastfeed? So those are some of the differing definitions that we need to clear up when we really kind of measure breastfeeding. Factors that are not controlled. A lot of the work that we do is really descriptive, which means that, among the people who live in this area, how many of them breastfeed, versus, okay, what are really the factors that influence this relationship? Are we controlling for those factors? It could be, some of the factors that we're not looking at may be affecting some of the associations we're looking at. So basically, we need to examine that. Definitely racial disparities has to be one of the priorities, mainly because there is a huge disparity in breastfeeding that we need to understand. So having said this, I want to bring you back to Richmond City and some of the, so all this research really helped us to frame our work. And I just wanted to take you to think about some of the data that we have, and this is from WIC data that we have from 2010. And in Richmond City, only 4.3% at that time were fully breastfed, and this is the way they defined it. So, it's not the common definition that probably you're used to. And in Virginia, it's 6.7, and overall in the nation, it's about 10.3. This is just looking at weak data. So, as you can see, the rates are very, very low, and this is what got us to think so Rose, when she came up with when she was charged by the mayor, and we started to look at the data, this terribly shook us really from the ground. We felt like we really do need to do something about this data. And so the first thing that we did was what are the opportunities? Actually, Rose was the one who looked at this funding opportunity, and she sent me an email, hey, Sawa, would you be interested in this? Can we work on this together? And we started working on it. We put it together. And the funding agency wanted to do interviews with us, and we went in and we talked to them about the problem, and truly sitting down there, we were finishing each other's sentences, and that made them convinced that we are really talking about the same thing. And also we have the community voice. We have also Cecilia Barbosa, whom I want to acknowledge in this work as well. And we were, really thinking from community university perspective. We did speak the same language, and that helped from getting that data or funding. And then we did a mixed method approach, and we did some qualitative data collection as well as quantitative data collection surveys and also focus groups. And here are some of the focus groups results that we got from our data. So the main question for us was, okay, if we're going to this community and working, what are the common factors or the barriers for this population, and what are the facilitators or what are helping them? And so we went out and recruited women and started talking to them. And after talking to them, these are some of the themes that we looked at. So from all of the groups, meaning all of the focus groups that we have done, there is definitely a common understanding that they know that breastfeeding was beneficial. So that actually took out one of the myths that we had, that maybe they don't know the benefit. They do know the benefits. So when we talk to them, they say, yes, we do know the benefits. And do health professionals encourage breastfeeding? They all felt like they were encouraged, but they didn't get a lot of hands-on help that they needed. The other thing is that the mixed influences from the social network that they have, which is some negative, like my mom says, why would you want to breastfeed? Please do not even consider that. Versus that mixed type of approach or mixed messaging. And then the week was also another major it's not really a problem, but more of a situation where they felt like conflicted in a way. So they thought that WIC was providing them information about breastfeeding, but at the same time, if you're fully breastfeeding, you're not going to get your formula. And mothers feel like, okay, if I don't get formula, just in case my milk is not sufficient, then no, so I better not breastfeed, so those kinds of conflicting information. Yeah. Okay, all right, so yes, so this is some of the areas. And then another from the quantitative data, these are some of the factors that came out, like attitudes, and it's really some of the CDC's recommendation align with it. So in terms of our local research agenda, we want to do further intervention-based practices. We want to use evidence-based models to do the work, and Susan is going to be talking more about that, some cost-effectiveness work that we were able to link data from DMAS, WIC, and also birth certificate data to really look at all of the breastfeeding and as well as some of the cost data. Integrating with other programs, we are working with home visitation programs, nonprofit organizations that are evidence-based. We have centering pregnancy programs that really work with pregnant women. And also we have community-based support groups that works in the community providing education. So we really would like to do more of an integrated program with our women, reach them where they are versus asking them to come to where we are. And that's really the biggest place that we want to be.
So save questions to the end.
All right.